So this is my topic for today, MD Diastology, and I have 20 minutes to cover it. It's a pretty vast subject, and we'll see what we can do with this. First of all, I would like to thank Dr. Muralidhar and the organizing committee for the opportunity. I'm from Bangalore, and I've been here a couple of times before, and this is great. I get to see family, enjoy the weather, suffer the traffic, and see all of you guys here. Conflicts of interest. I don't have any conflicts of interest. I run a fake course at the University of Minnesota, nothing to do with this. And yes, I have to declare something else. This may be a little boring. So one of the uses of diastology I found is it may be a sleep aid. Invariably, you turn the lights down, postprandial, people go to sleep. So I'll try to keep you awake. I'm actually happy this is happening just before lunch. Maybe the hunger will keep you awake for this 20 minutes. Right, so aims and objectives. So we'll see briefly why LV diastology is important. Echo-evaluation of LV diastology. We'll take a look at some of the ASC guidelines and we'll summarize at the end of it. So why is diastology important? So there have been multiple papers looking at prediction of all-cause mortality in patients with EF more than 35%. And what they found here is this. So if you have diastolic dysfunction, even in patients who have a normal EF or EF by 35%, it does increase the risk of all-cause mortality. And how about outcomes, other outcomes? So this is a systematic review and meta-analysis of diastolic dysfunction on post-operative outcomes. What they found is grade 3 diastolic dysfunction is associated with higher perioperative death and mortality, regardless of the ejection fraction. So this is all great. So what do you do with this information? Let's say you find somebody who has heart failure or preserved ejection fraction. That's the new and fancy name for diastolic dysfunction. So it's a busy slide. I don't expect you to read every bit of it. But if you see the outcomes, mortality, hospitalization, nothing has changed there. It says, that's the medications that I've used. ACE inhibitors, ARBs, beta blockers, and there's some more unconventional stuff. But the outcome, there's been no change, at least as of now. It's complex. LV diastology is very complex. This you might have seen in all your previous lectures on diastology. It's complex because it's not just a simple mechanical event, which we thought it was. There's active relaxation, and there's restoring forces, and the lengthening load. This is the left atrium pushing blood into the left ventricle. And then, LV filling pressure. So if you want to understand what LV filling pressure is, which is a key component of LV diastology, it can be LV and diastolic pressure, left atrial pressure, or wedge pressure. And then, based on what we see on our echo exams, there are events that occur at the end of diastole that represent more of the LV and diastolic pressure. And there are earlier events, like the E velocity, the deceleration time, E by E prime, TR velocity. All these will give you a measure of the PCWP. Now coming to the ASC update on LV diastolic dysfunction. So these people, the American Society of Echocardiography, they're given guidelines much earlier, and then they realized it was too cumbersome. If you have to go through every single parameter to make a diagnosis, it's not easy for anyone, not in the cardiology lab, and definitely not in the perioperative setting. So they came up with guidelines to simplify that. So in the perioperative setting, this is something you need to remember. It's not for children, and this is the wording exactly from the guidelines, not necessarily in the perioperative setting. And we are talking about diastology in the perioperative setting. And these are the best guidelines we have out there. And if the quality of data is not optimal, don't use it to make a decision. And do not use any data in isolation. That's just putting into practice. And these guidelines are based on expert consensus. There is no hard evidence for this. So if you see the AAC guidelines, the focus has been on 4 key parameters. You look at the velocities. You do like, it's based on all like 2D and tissue Doppler. You look at the E by A velocity in the transmitral flow. You take the E velocity and then you take the E prime, which is the tissue velocity either in the medial or the lateral aspect of the mitral valve annulus. And then you look at the E prime itself in isolation. Then the tricuspid regurgitation velocity and the left atrial volume. So people who practice transesophageal echo, how many times have you calculated the left atrial volume? I haven't. So it's not easy, right? But this is part of the guidelines here. That throws things off a little. And these are the magic numbers. So if the septal, if it is less than 7 centimeters, lateral annulus tissue Doppler is less than 10 centimeters per second, and if the E by E prime is more than 14, the LA volume index is more than 34, and the tricuspid regurgitation more than 2.8. And it's not necessary that in all patients you will see tricuspid regurgitation. And the vision test. So if you look at the AAC guidelines from 2016, like they've gone in detail and describe like exactly where you need to like measure these parameters and the analysis of that. I don't have enough time to like go through all of this, so I'll skip this part. Couple of the key things in the AAC guidelines. They have divided this into like patients with normal ejection fraction, and then there is like patients with low ejection fraction, or if they have myocardial disease. So this is the algorithm for patients with normal ejection fraction. So if you see here, this same four like key parameters show up. The average E by E prime. So when they say average, you have to take the medial and the lateral, and then take the average of those two. And then the septal velocity to the lateral velocity, those are the magic numbers there, 7 and 10. The TR velocity and the left atrial volume index. And then you start like working your way down the algorithm there. So if it's less than 50% positive, then it's normal. So less than 50% positive would be like, you should be able to see like out of the 4, only 1. If it's 50% positive, it's indeterminate. And if it's more than 50% positive, only then you can say it's diastolic dysfunction. For the perioperative setting, TE, if you take the LA volume index out, it's only 3 of them. And they left it at this. Again, all these guidelines are based on expert consensus. And the whole premise of like these guidelines is to estimate the mean left atrial pressure. And what about like patients with depressed ejection fraction or myocardial disease and normal EF? So these are the patients who have like cardiomyopathies, HFPEF, stuff like that. So this is a little more complicated. So you look at the mitral inflow data there. So if the E by A ratio is less than 0.8 and the E is less than 50 centimeters per second, then you're done. That's normal. And if the E by A ratio is more than 2, then you're done. It's like grade 3 diastolic dysfunction. This is the gray zone. So here, I think they realized like, in the perioperative setting, you won't get the left atrial volume measurements. So they said like when you 2 criteria are present, they gave you some guidelines. When you can say it's normal, when you cannot determine LV diastolic function, or if it's increased. So again, like this is a tabular representation of like the previous slide. So you look at the E by ratio, if it's more than 0.8, then you go through this, like even less than 2.8 for the TR velocity, then it's normal. And this is the best part, like when you're in the preoperative period, you look at the E by ratio, if it's more than 2, then you don't have to like do much else. Then like the patient has diastolic dysfunction. So special situations, this is like most of our practice. Patients with atrial fibrillation, mitral annular calcification, mitral stenosis, mitral regurgitation, aortic regurgitation, stenosis, and HFPEF. I don't think I have enough time to go through each one of them, but I'll give you like broad strokes as to like what to do when you see patients with all these problems. Atrial fibrillation, as common sense dictates, the beats are not regular, the cardiac output changes, so we have to take an average of like multiple beats there. What about MAC, mitral stenosis, mitral regurgitation? If all of these velocities are mild, then you should be okay to apply the same guidelines. But if the MAC is high, if the mitral stenosis is high, or the patient has a prosthetic valve, you cannot use tissue Doppler because the movement of the tissue on the annulus is affected by these pathology themselves. You cannot use those. But interestingly, the TR velocities they found it remains valid in most of these comorbid conditions. So TR velocity being high, what does that mean? In the absence of pulmonary vascular disease, it's kind of like you're estimating the PCWP indirectly. The left atrial pressure is high, so there's no pulmonary vascular disease, then you would trace it back. High left atrial pressures, high pulmonary pressures, high RV pressures, then resulting in tricuspid regurgitation. And if you have a severe AR, then you have to keep in mind the AR jet can interfere with your transmitral flow measurements. So what about age? As people get older, the LV gets stiffer and slowing of the myocardial relaxation happens. The E by A ratio and the E prime velocity, they all decrease. But individually, though the numbers will decrease, the E by E prime ratio is less affected by age, so that you can use it more reliably. Now, we have been talking about all this, that there is no effective cure for this, so why is it important for us to check on diastolic dysfunction in the perioperative period and let the surgeon or the physicians know? So this is for managing patients like in the post-operative period and for ruling out like certain pathologies. So we'll go through a couple of case studies. So this is just so that you get an understanding of the AAC guidelines. 64-year-old male, 4-vessel CAB, comes in for a 4-vessel CAB. His EF is preserved and no valvular dysfunction, no hypertrophy of the left ventricle. What's his diastolic function at this point? So let's take a look at the mitral valvular velocities there. So if you see here,
Hello.
So the E by A ratio is 1.1 and the velocity, the E velocity is like 55.4. Okay. So the tissue Doppler velocities. This is the septal tissue Doppler. If you see here, it's like 7.7. And this is the lateral velocity there. So that's like 11.3. Okay. And we also check the pulmonary venous flow. This particular patient, we do not have tricuspid regurgitation, and of course, we couldn't check the left atrial volume itself. Let's go back to that algorithm then. So this is our algorithm. What numbers did we have? If the E by E prime is less than 14, septal or lateral is 7 and 10, TR velocity not obtainable in this patient, right? So what we found here is this. Sorry, let's go back here. So see that the E prime is 7 for the septal, and it was 11 for the lateral. Yeah. So E by E prime less than 14. The guidelines say if it's more than 14, that counts as like something that we need to consider for diagnosing diastolic dysfunction. The septal is more than 7, the lateral is more than 10. We couldn't get TR velocity, we don't know the LA volume. And if you follow these guidelines here, it's less than 50% positive. The patient has normal diastolic dysfunction or normal diastolic function. So Dr. Swaminathan did this landmark study for assessing diastology in patients who have undergoing coronary artery bypass. None of these patients had valvular pathology. The purpose of the study was to see if a simplified algorithm is as good as a more complex algorithm. So this is from 2011 when the AAC guidelines had not been revised. So what they did was they looked at just this, the ones in gray is what they were comparing. This was like the simplified algorithm as opposed to checking all these parameters, which is part of the algorithm for diastolic dysfunction from the previous guidelines. So what they found is the ability of the cardiac anesthesiologist to look at diastolic dysfunction using a simplified algorithm. They could diagnose more patients. And coming back to our patient, the lateral E prime was 11 centimeters there. is like grade 0. So in this particular patient, like it coincides. So what they found is patients who were diagnosed with diastolic, grade 3 diastolic dysfunction, they had like a worse outcome, and these patients are followed up for 5 years. So diastolic dysfunction is harmful, but we still don't know like how to diagnose it, like what to do with the information. So this is a different patient, depressed ejection fraction, mild mitral regurgitation, 6 to 7 year old male. So these are the values that we got. So if you see, the velocity for E is like 77.8, and the E by E ratio is 1.8. And this is your tissue Doppler. We got the lateral at 7.61. So we got tricuspid regurgitation velocity, which is like about 250 centimeters. And this is pulmonary venous flow. So we'll come back to this algorithm here. So if you see, E by E is 1.8. So that will put us somewhere here. Right? And then E by E prime is 10.6. So once you come into this part of the algorithm, then you see like what the average E by E prime is. It's not more than 14. 10.6 not more than 14. And then the TI velocity we got was 2.58, which is less than 2 meters per second. So when only 2 criteria are available, so we have 2 negative. So that will take us to normal left atrial pressure, grade 1 diastolic dysfunction. Pop quiz just to see if you guys are awake. So this is from a patient who came to us for, I'll tell you what the procedure was later. So his lateral E prime velocity was 12.5. Then the medial one was 13.2. This is, let's say the medial was not 13 but 19. What do you think the pathology here is? Okay, and there's a name for that, right? What is it called?
Annulus
universus. Good. You guys are taking the exam this time? I hope so, because this shows up for the exam like pretty often. So this is an unusual situation where the velocities on the medial side are higher than the lateral ones. That's annulus reversus, very typical of constrictive diabetes. Okay. Right. So in summary, diastole is important. It's very complex. The echo assessment for diastolic dysfunction based on the AAC guidelines is heavily based on TTE rather than TEE. It's an evolving field, and we're still learning like what to do with the information that we have. So hopefully in the future we'll know what to do. Right, that's my. Any questions?
Is there a role of mitral valve propagation velocity?
Yes. So VP, it looks very colorful when you look at it. There are particular instances where it's useful. I think it's a measure of PCWP in patients with low PF. We take the ratio of PCWP by D or U prime. But in reality, again, like this is all based on TTE. It's not doesn't figure in the AAC guidelines itself. They have mentioned like very briefly like what it is. But just for fun, like when I'm practicing in the operating room, I measure the VP velocity. But one of the reasons why like people get attracted to echocardiography is like it's very colorful. It reminds me of like the video games I used to play as a kid. But to answer your question, it is useful, but not widely practiced.
So in the last simplified algorithm you said, the E by E prime is the average E by E prime or one of the bigger lateral?
That's
The last simplified one.
I think it's a lateral one. They propose it only for patients undergoing CABG, not other valvular pathologies. But in the paper they say it can be like used for other patients, but it's not been validated.
Just a comment about diastole. At the University of Melbourne, we have done away with these complex measurements. This is a study published in 2014. It said interatrial septal motion, but not Doppler assessment, predicts elevated pulmonary capillary wedge pressure in patients undergoing cardiac surgery. the symptoms. I was a part of it. So we often look at the interatrial septum, and from that we look at what the LA pressures are. If they're high, obviously it's bulged both during systolic and the diastolic phase to the right. And we generally tend to go on that to say, okay, this diastolic failure. But as you correctly pointed out, there's nothing you can do about it. And in the perioperative setting, it often changes. So what we have, just let the lungs not be ventilated for some time, then you can note the change again ventilate, again it changes. I think that's important for a lot of people to understand, is that in the perioperative setting, there's a constant change, it's a dynamic environment. So don't be too much hung upon that what's happening to the diastolic thing. And the other fact is that we really can't do much about it except for some of the irreversible cause of decompressing the right-sided circulation. And I think most importantly with LV diastology, the right ventricular pressures, that's to be kept in mind.
Yeah, because R is much harder to protect than the left side. And you're right, like the perioperative period is such a dynamic event that what you see at one particular cross section, like it may completely change in 5 minutes from then. Which is why most perioperative echo reports at my institution, like the LV diastolic dysfunction is indeterminate. So you can't determine it.
In a pediatric subset of patients, what about the RV diastology, especially in tetralogy and fellow, in the perioperative setup? So are there any guidelines or anything management issues that are on RV diastolic dysfunction?
RV diastology no, actually I don't know much about that. I don't practice with congenital hearts in my practice. I don't know, maybe you do. You can tell me.
So on OPD basis in stable patients, can we use Valsalva to confirm what kind of diastolic dysfunction is there?
So Valsalva, if you look at on the guidelines, it's useful to unmask pseudonormal patients and to confirm restrictive diastolic dysfunction. If it changes from, what the premise is that your preload is going to come down. If it improves, then it's pseudonormal. If it doesn't change, you've gone too far and you can't do much with it, that's when it's restricted.
Yeah, now that we know that diastolic dysfunction will influence the outcome, do you think it should be included in the Euroscore and other scoring systems so that we can add up to the score and exactly predict the outcome?
Yeah, it's in its infancy. There's a lot of opportunity for research in this, and it may be interesting to see what the diastolic dysfunction is. Let's say somebody comes in for a CAB. You see what it was before, pre-op, intra-op, and then post-op, and see how the revascularization changed it, and follow it through maybe Euroscore, a SOFA score in the ICU. I think a lot of people. I took my critical care ultrasound course recently, and I was fascinated that people are using the E/E prime ratio in the ICU to predict volume responsiveness. And I spoke to a few of my friends here, and they said they do it every day. So even in US, we are not that advanced. Look at the E/E prime in the ICU patients. Most of the times at the point of care, we just look at myocardial contractility. So diastology is, I think it's in its infancy here, and we don't know what to do with information. We don't know the guidelines are based on transthoracic outpatient setting. So there's a lot of scope for research.
I think there's a question from Dr. Kanji. As a cardiologist, I think putting in a Euroscore, how many parameters we are going to put in a Euroscore for risk calculation. So, and the diastology is such a difficult group with multiple parameters and numbers and non-reproducible. Everybody should know whatever the parameters you have, it's a non-reproducible. So that is where it becomes more difficult to put it in a Euroscore for risk stratification. So, and we struggle. We want to do for a CABG into a neuroscore. It is easy for me to put a patient in a multidisciplinary team and say his neuroscore is high. I will take him for a TAB-E, but it's not cost effective.
The problem we face is when the patients undergo CABG. What I have noticed is most of them have grade 1 diastolic dysfunction. Maybe because of the underlying ischemia or because they are in that age group where they have diastolic dysfunction normally. So I'm not sure what happens to them after CABG. We should, I think, as you said, to follow them up and see if it is ischemia related, they should be able to improve it. And that is the point I would like to make.
I think I missed the talk, but I think the reason we need to know diastolic dysfunction is when we clinically take care of these patients, their reserve is going to be less than somebody who has normal diastolic function. So we got to monitor them closely. We got to watch for how we dose the anesthetics, especially for non-cardiac surgery. We take care of a lot of patients who are elderly, and they need to be closely monitored. And so it's good to know how bad the diastolic function